Great. So for our next session is one that I think we're all very excited about. So it's my pleasure to introduce Professor Richard Holt, who I've also had the pleasure of working with in his young adult clinic. So I know that he's an amazing clinician, and he puts patients at the heart of his clinics all the time. He's published over 200 articles, as well as the EASD Type 1 consensus statement that we all use. You do a lot with EASD, don't you? I forget all your titles, I'm sorry. But you also have a PhD, and you're a lecturer in endocrinology and metabolism. Works at University Hospital Southampton, and his subspecialities within diabetes are the cystic fibrosis clinic, young adult clinic, and pregnancy. So you've got lots of experience in pretty much everything, and mental health as well, don't you? So lots. So yeah, please come up. Have you got? That's great.
So good afternoon, everybody. It's a great pleasure to be here. Beth, thank you very much for that very kind introduction. What Beth didn't say is that I have no experience in neurodiversity. So I have to say that when I was asked to give this talk, I had a certain trepidation about getting up and speaking about neurodiversity. And I thought, well, okay, well, I'll give it a go. Beth's obviously got confidence in me to do it. So I went to PubMed, as you do when you all start the talks, and typed in the words diabetes and neurodiversity. And do you know how many hits I got with that? 4. So it could have been a very short talk, but I've done a little bit more reading about it, and I hope that I can share some of the things that I've learned over the last couple of months since I prepared for it. But I also hope that there are others in the audience who will be able to either correct me or to add and have some shared experience about how we might think about this particular problem. So what I'm going to do is just start off by getting us all on the same page by letting you know what I understand as neurodiversity, and then look at the relationship between neurodiversity and diabetes, and then think about what that actually means for clinical practice. And I'm going to also shape this around a case history of a person that Beth will probably remember, and Leah will also remember, from the young adult clinic in Southampton. So actually, I'm perhaps not surprised that I didn't really quite understand the links between neurodiversity and diabetes, because as a terminology, it's actually relatively recent. So the first time that this word neurodiversity appears in an academic publication was back in 1998, and it really came out of a movement to try to prevent some of the stigma and discrimination that people with autism were experiencing. And the idea was to try to reframe our understanding of autism and ADHD as really thinking about differences rather than pathology. So to think about the differences and disabilities that people experience with these conditions, and to just understand, as people who are not neurodiverse, how these individuals understand and think about and experience the world, and understand that how, when they see the world differently, that then has an impact on healthcare and the way that we as healthcare professionals may interact with those individuals. So since those original publications, the term neurodiversity has expanded. So initially it really started, as I mentioned, in this relationship with autism. It then rapidly was expanded into ADHD. But then beyond that, there were a whole load of other conditions that were added to this concept. And in fact, it's also been expanded to include people with antisocial personality disorders and also severe mental illness. Now, you know, it may be a point for discussion when we have time for questions at the end about whether ever expanding what we mean by neurodiversity is actually a good thing, or potentially can dilute away some of the really key messages that we might need to think about in terms of people with autism and ADHD. But what we certainly know is that people from any of those groups of individuals have poorer health outcomes, whether they be diabetes, as I'll show you in a minute, but also other diverse chronic conditions as well. And we also know that people with neurodiversity also experience premature mortality. But I'm going to try and focus my talk mainly on autism, but I also add a few words about ADHD because I think that's where the focus of what I'm going to be talking about. So what do we mean by autism? Well, it's a condition that's characterized by difficulties in social communication and reciprocal social interaction. And what that means is that those individuals may have persistent, restricted, repetitive, inflexible patterns of behavior, interests and activities. And when you start to think about that, you can understand how that will have a major impact or could have a major impact on their abilities to self-manage their diabetes. When we think about ADHD, these are also persistent patterns of behavioral changes that include things like inattention, hyperactivity or impulsiveness that can then have a direct negative effect on academic achievement, occupational achievement, and also functioning within society. And these conditions are not rare. So in a study from the US looking at children aged between 3 years old and 17 years old, about 15% of those children had one or another neurodevelopmental disorder. So that's actually quite a lot. And perhaps we don't recognize it because particularly I think girls are quite good at trying to hide it. They develop tactics and behaviors that allow them to hide the fact that they are experiencing some of these problems. So as I mentioned, I'm going to try and illustrate this around a case history of a young man that I saw in Southampton. His name's Alex, and he's also given me permission to share his case history today. And you'll notice that he's an art student, and he's also given me his permission to share some of his artwork with you. As a sideline, I'm now Alex's agent, and if you'd like to purchase any of this, please see me afterwards, and I'll be very keen to take commissions. No, that was a joke. So he'd been diagnosed with type 1 diabetes at the age of 10 years old, and when I saw him, and indeed I actually only saw him yesterday, he doesn't have any diabetes complications, and I met him for the first time in the transitional clinic, having been looked after within the paediatric service in Southampton prior to moving up. He was using an analog-based basal bolus insulin regimen, and at the time, he was using a Dexcom G7 continuous glucose monitor, which was linked to Clarity. But interestingly, he said, I don't believe the CGM. There's always a difference between the CGM and what I do with my finger prick testing. And we all know that happens, but this caused him a lot of distress, this discrepancy between the two different readings. And I think, again, that probably was reflective of his particular condition. And when he came to see me, his HbA1c on transition was 61 millimoles per mole, so it wasn't particularly elevated, but it was notable that over the 2 years prior to him transitioning to the adult clinic, that his HbA1c had gone up. Now, I mentioned to you that he kindly allowed me to share some of his artwork, and this is some of the work that he has been doing, and I'll show you some more of it later on during the talk. So as well as his autism, he also had a learning disability. He was living with foster parents and had been living with the same foster parents really for a number of years. But over the years leading up to the transition, this relationship had become increasingly difficult. And part of that was because Alex was wanting to start to think about being more independent himself and wanting to make choices for himself, whereas his foster parents, who had very successfully, I should say, helped with his self-management when he was a younger boy, were feeling that they were very constraining of his behavior, and actually this was becoming a major point of friction between him and his foster parents. So we had a number of challenges within the team when we first met him. So the first thing was that when he first came to the clinic, he would hardly say anything. He was very shy within the clinic and was quite withdrawn in the clinic. And I have to say, it may be that the size of the multidisciplinary team that we had within the diabetes clinic was actually intimidating for us. So within the young adult clinic, we usually have 3 or 4 healthcare professionals in the room at the same time. So as well as me, there's always a diabetes specialist nurse. Sometimes we had a dietitian in the clinic, and sometimes we had somebody from a psychology background in the clinic as well. And it's not a big room, I have to say, and that could well have been quite intimidating for him. Of course, he had problems with his learning disability, and his foster parents said that he could become very overwhelmed with information, overwhelmed by the environment that he was in, and that could actually cause quite a lot of challenge within the clinic. And as I've already alluded to, he was already struggling with issues with his foster parents, and that was causing a little bit of a frosty atmosphere within the clinic. But I think, thinking about Alex, I think it really raised, or at least raised 4 questions in my mind about what we needed to do to try to help Alex achieve the best possible outcomes in terms of his diabetes. So the first question that really came to mind is diabetes more common among people with autism than in the background population? Now, in Southampton, the way that we run our young adult clinic is that we split it between those young adults who are on pump therapy and those who are on multiple daily injections. And I tend to look after the people with the multiple daily injections, whilst the pump team actually looks after those individuals separately. And I have to say that over the years that I've been doing the clinic, I have had this feeling that there are more people coming to my clinic who had either autism or ADHD than I might have expected from the general population. The second question is, does diabetes itself actually increase the likelihood of somebody going on to develop autism? And when somebody has both of these conditions, does it actually interfere with diabetes care? And do we need to adapt our care in order to help maintain insulin safety, but also to improve diabetes outcomes for these individuals? So, as I said, go to the literature. There are only 4 papers, but fortunately, if you start to subdivide, you start to see some of the answers to this question. So the first question about whether people with autism have a higher risk of diabetes is actually correct. So people with autism have about a 50-odd% higher risk of developing diabetes compared with the background population. And interestingly, the risk for type 2 diabetes is actually higher than for type 1 diabetes. But both conditions are more common. What about diabetes? Does that actually increase the risk of developing autism? Well, actually, again, we can go back to the literature, and it looks at that overall, across a number of different studies, that having diabetes does not increase your risk of autism. But having said that, if we start to look more broadly than autism and look at other neurodevelopmental disorders, and then start to subdivide according to levels of blood glucose, we do now start to see some differences. So what we can see on the left of the slide is that if we look at any neurodevelopmental disorder, those individuals who have higher levels of glucose as assessed by HbA1c, they have a higher risk of developing a neurodevelopmental disorder. Across autism, we don't see so much of an effect, and it seems that probably that left part of the slide is largely being driven by an increased risk of ADHD among people with high HbA1c. And similarly, we also see the same sort of pattern for people with intellectual disabilities. And it was interesting, I was speaking with Rose Stewart just before this over lunchtime, and she was saying that there have been some MRI studies actually looking at changes in neurotransmitters within the brain, showing that there are changes that can occur during hyperglycemia that may impact some of the neurodevelopmental pathways. So a very interesting area. But one of the other interesting areas, and I think when we start to think about transgenerational effects of diabetes, is that where a mother has diabetes, there is an increased risk of developing autism in the offspring of those mothers during pregnancy. So again, big plea for optimizing our pregnancy services in order to help not only the short-term outcomes, but also more longer-term outcomes of babies born to mums with diabetes. So I think what we can see is that this is a common, these two conditions occur together more frequently than we would expect by chance. But does that matter? Does having autism interfere with diabetes care? And the answer is yes, it does. But some of the things would perhaps be more surprising, some perhaps less so. So the first thing that we actually see from this particular study, which is the Type 1 Diabetes Exchange Registry from the US, is that if we actually look at the ratio between males and females, we can see that among those with autism, there was much higher numbers of boys. No differences in the rates of diabetic ketoacidosis, no differences in the use of CGM, and perhaps that reflects the fact that CGM has almost become universal now for people with type 1 diabetes. But what we do see is that people with autism are less likely to be offered pump therapy. And that has to be a healthcare professional thing, doesn't it? You know, we are projecting our views onto whether somebody will be able to manage with a pump or not, and therefore we may be disadvantaging people. In terms of complications, overall, we can see that if you have a neurodevelopmental disorder, you're perhaps more likely to develop a diabetes complication, so more nephropathy overall, more retinopathy among people with autism, more nephropathy, and we've just heard about the challenges of renal disease among people with diabetes in people with ADHD and intellectual disability. So there is a pattern that we're starting to see that where individuals have a neurodevelopmental disorder, they are more likely to have poorer diabetes outcomes. But again, this may reflect what's actually happening in terms of our service delivery. So again, this is a study from the United States, looking at the likelihood of somebody having an HbA1c measured, having their cholesterol measured, having a retinal examination or microalbuminuria. And what we can see is that compared with the background population, either whether they have insurance or publicly based healthcare, that the likelihood of you having your care processes undertaken if you have a neurodevelopmental disorder is reduced compared with the background population. So what do we need to do in order to try to optimize healthcare for people like Alex and other people with autism or ADHD? And I think it's also telling if we actually go back and ask people with autism and their families what they are telling us about the healthcare that they receive. So one of the things that they say is that people, mental health care professionals who know about autism, but they don't know about diabetes. And people who know about diabetes don't know about autism. And that creates a challenge because you're not getting that multidisciplinary levels of understanding that go across both groups. And you can understand that where you have comorbidity, the burden of living with both of those conditions is higher, and that creates challenges within the school. And we all know about some of the challenges that children with diabetes face at school, but just imagine you add that to people with autism or ADHD as well. They're also saying that there's a need to think about managing their diabetes because of the effects of either hyper or hyperglycemia and the risk of going into hospital. There are challenges about using some of the latest technology to manage diabetes. So one of the things that people with autism can really struggle with is multiple alarms. I mean, we all hear about alarm fatigue anyway for people with either pumps or CGMs, but that anxiety, that frustration, it can often be magnified among people living with autism. And frankly, there's a lot to learn, isn't there, about diabetes? And you then add that onto some of the learning challenges that people with ADHD and autism have, and you can start to understand why this becomes more challenging. And one of the things that was very clear from this particular study is that people with, or families with children with both diabetes and autism really wanted was to have a joined up service. So you don't have mental health over here and diabetes over here. We need to think about trying to bring the two together. Now, one of the things that's also spoken about a lot in the literature is this concept of the double empathy problem. I mean, I hope as healthcare professionals, we are empathetic when we see the people in our clinics. But the issue about the double empathy problem is that it's more difficult to establish that empathetic therapeutic relationship with somebody with autism and or ADHD. And part of the reason for that is that if you have autism, you might struggle to understand some of the social cues and the non-verbal body language that we use in order to communicate with our patients. We use analogies. We say things and we expect people to understand and to read between the lines. And that can be difficult for people with autism. So they find it hard to relate to you as a healthcare professional. But equally, healthcare professionals might find it harder to relate to somebody with autism or ADHD, because if you have somebody who is withdrawn in the clinic, is not coming across as being communicative, not engaging with you, then it becomes harder for us as healthcare professionals to start to relate to those individuals. And this can then lead into a vicious cycle. So how somebody behaves to you and how you understand that behavior dictates how you respond to that behavior. And then your response is then interpreted and perceived by the other person on the side, and that can then lead to changes in behavior. And you can see how we can get ourselves into a very negative, vicious cycle in terms of creating that therapeutic relationship as a result of the difficulties in understanding. And often the problem is that people with autism are blamed for that difficulty in communication. So the person with autism can find it difficult to read and understand what people are trying to say through their non-verbal communication, through the analogies they use, through the reading between the lines. And that's seen as their fault for not having what is an expected life skill. And at the same time, we as healthcare professionals might find that person with autism difficult to read. And of course, it's still the problem of the person with autism because it's their fault for not communicating more clearly. And that's the challenge that we face. And there are also very specific challenges about people with autism when they come to a clinic. It is most definitely out of their comfort zone. It's out of the routine. It's unpredictable. Often, so I don't know about you, how long do your patients wait in your clinic waiting rooms before they see you? Can you guarantee you will see them on time? No, of course we can't, and that's just the way it works. But you know, it's frustrating for all of us. But those frustrations can be even greater for people with autism. And then suddenly it's like, right, your turn, in you come. And that sudden transition can be difficult to meet, can deal with. There are often new people. I mentioned that one of the challenges that Alex faced was those 4 people in the room that he'd never, well, he had met 2 of them before, but 2 new people. And there might be lots of new information, lots of things happening in that room. So, there might be visual things on screens, there may be bleeps going on, there may be other things that are actually happening. And that can be challenging. And sometimes we might actually remove some of the things that might be the coping mechanisms that people have to survive with their autism. And can you imagine the frustrations that there are then when people can't express how they feel and what they need to do? So I don't have all the answers, and I'd be really interested to hear from you during the Q&A about how you would handle and support people with autism. But here are just a few tips that I've gleaned from reading from reading the literature before coming to do this. So the first thing is learn a bit about autism. Get the training. So quick show of hands. How many of you have had training about how to provide better diabetes care for people with autism? So actually, that's probably more than a...
No, not specific to diabetes. We have
So maybe, so there was probably about a third of you. I mean, I've never had any specific training about this. But maybe we need to think about how we do that. I think it's also important that we understand that this is going to be difficult for that person when they come to the clinic. But it's important that we make them the centre of the consultation. There's always that temptation, isn't there, to speak to the carer, the parents, the friend, because if it's easier to communicate with them, and that can be very frustrating for that person with autism. We need to recognise that we might need more time in the consultations for this. We need to understand that people with autism might have different learning styles. So it may be that we don't just use verbal cues. It may be that we need to provide written information or in pictorial form in order to help people understand. There's also that writing reflex, isn't it? Well, that's not what I would do. I would do this. And I can tell you that Alex's carer used to tell me that if we did that to him, he would react really badly and then struggle for the rest of the day because as he was reflecting what we said. So it's really important to think about that. And actually emphasize the positives. Nobody has got perfect glucose management, have they? Nobody has. And yet, what we need to be thinking about doing is nudging people into the right direction. And I think it's also important, as you'll see from Alex's case, that we need to think more broadly than just the diabetes management and think about how the diabetes fits within that social context of that individual. So here are a couple more of Alex's paintings that he did while he was at college. So what did we do in order to try to support Alex? Well, the first thing that we did was for one of the paediatric diabetes specialist nurses and one of the adult diabetes nurses to go and visit Alex in his home before he actually came to the clinic. So at least he had met one of the new team before he actually came and was briefed on what to expect when he came to the clinic. So it wasn't quite such a leap into the unknown that it might have been. We actually gave Alex time to talk about him and himself. And one of the things that's always lovely about Alex is that once you start to talk to him about his art, he lights up and really starts to talking. And you can often use that as a bridge to start to talk about his diabetes. So it was trying to find that lever. Now, clearly not everybody you see is going to be as good an artist as Alex, but there's often that way of trying to find that way of engaging with that individual. We offered support to give him a place on the Princess Wales Trust scheme, and he enjoyed doing that. We actually liaised with the social services about the challenges that he had with his foster carers, and those were changed. And actually making that change helped Alex to make that transition to looking after his diabetes more himself, still being supported by his new carer, but not in the same way. And that made him much happier. And so what we were able to do over a number of visits was start to build the trust that we really felt was necessary in order to really support him. And he is somebody who now always regularly comes to the clinic. He's actually much happier. He's much more confident in the clinic and much more open. And every time he brings a new piece of artwork for us to look at, which is just fabulous. So I guess I've really just only scraped the surface of this particular issue, but what I hope that I've illustrated over the last 20 or so minutes is that people with diabetes, young people particularly, have a higher risk of autism and other neurodevelopmental disorders compared with the background population, and that has an influence on their journey with diabetes, such that diabetes outcomes are often worse among people with neurodevelopmental problems. Now, I think that it's a real onus on us to think about the ways in which we need to think about our clinical practice in order to adapt the way that we run our clinics in order to best meet the needs of these people with diabetes. So thank you very much for listening, and I'm very happy to take questions.
Amazing. So we have got a few questions come in, but if you do have any questions, you want to pop your hand up and you haven't had a chance. So one of them says, has this topic made you want to do more research into it and develop some consensus statements or anything? I know you love your research.
I mean, certainly, it is a really interesting area, and I think what I hadn't really appreciated was quite some of the challenges. I think there are certainly lots and lots of opportunities to think about doing that. So, yeah, why not?
There you go. Next one. Sorry, you may have missed this. Why are babies born to mothers with diabetes more likely to have autism?
You didn't miss it because I didn't say.
There you go.
So there you go. The second half of the question is actually slightly harder. I think the worry is that the hyperglycemia during pregnancy can affect the brain development that then increases the risk. But I would say, again, this research is still very much in its infancy.
I suppose the next one is more of a comment than a question, which diabetes specialist nurses it reaches so many conditions, because I suppose a person with diabetes goes through all life stages as everyone does, but we're expected to be a bit specialist in gynae and menopause and a bit specialist in eating disorders now and a bit specialist in everything, so yeah, it's not really a question, but I suppose.
Well, I mean, I think it is an interesting point, isn't it? Because we are expected to look and practice in many different areas of medicine. And I think that's one of the joys about diabetes, isn't it? That we do actually think about interacting, and I think that's probably one of the fun things about diabetes, but you're right. Having said that, I don't think that we necessarily all have to be experts in all of these conditions, but what I do think we do need to do is have an awareness and know where to signpost people where there are problems.
Do you have any experience on patients who have sensory issues in terms of taking their injections? If so, how did you overcome it?
Rose,
this is a very nursey thing, and I said we are very lucky that Dr. Rose Stewart is here. We hate to put her on the spot because this is not technically her session. But Rose, if you do have any...
Yeah, this is my bag. So go and speak to your clinical psychologist, because this is something we've been trained on.
If we have one.
I know.
Not everybody does have a you.
We've written some guidance for JDRF that's going onto their website in the next few weeks on autism, diabetes, ADHD and ADHD, because you can have both. So in terms of sensory issues, if you've got somebody with autism, a big thing in autism is special interests. So a person is likely to have an interest that they are obsessive about. So with one of our young men, it is Star Wars. With my daughter, who's autistic, it's Greek myths and fish. Link things to their special interests would be my advice. So try and distract them with a special interest. So whether it is singing the Star Wars theme as you inject, whether it is sort of watching Star Wars while you're doing the injection. And that is a massive tip for engaging people, full stop. If you get onto their special interests, they will talk to you for several hours about said interest, but they will also be your best friend. So if you can find something about that, if you ask them about Star Wars or whatever new thing it is for them, that is a huge element of it. I think it's also really important to emphasise that there is an enormous population of people who haven't been diagnosed with neurodiversity, and I'm sure you've probably seen a lot of this online with people sort of self-diagnosing through TikTok, things like that. Particularly women. There will be a lot of women in this room who would meet criteria, and there will be a lot of women and men in your services. So that person who's got amazing control because they always eat the same thing every single day and have a very rigid routine, autism. Person who developed closed loop systems and never leaves their labs and can't have a conversation but is the biggest genius you know, autism. The person who's been through 3 Daphne courses but still can't seem to implement the things and says, I know what I need to do but my brain won't let me, ADHD. So these things are there. They are there in our clinics, they're there in our staff, they're there in ourselves, and we will probably see it everywhere. So it's really, really useful to go and train on this. AutismWales.org do a really, really good e-learning module. It is quite in-depth, but it is fantastic. So I'd really recommend doing that if you get the opportunity to.
Can you do that if you're not living in Wales?
I think you can, yeah.
Oh,
I think it's
good.
open to anyone.
Ah, perfect. Good. Okay. Thank you, Rose. What else we got? Do babies born from pregnancy-induced diabetes also, I guess it's gestational diabetes, also high risk of developing autism?
So, I mean, I think it's the hyperglycemia.
So yes.
Possibly, yeah.
Yeah. My son has ADHD and ASD, autistic spectrum disorder, and could have created very similar art. Learning about his neurodiversity and how to support him makes me better dealing with it. Yeah.
So maybe Alex's art was what Rose was saying about finding the thing that really interested him.
Yeah. Yeah, there's a lot. We had the type 1 artist. That was a lot of diabetes art and artwork there, wasn't there? So that was great. Would routine HbA1c screening for neurodivergent individuals help in early diagnosis of diabetes and treatment initiation? Knowing what to do.
No. It's more to do with lifestyle. So one of the unofficial autism criteria, especially in young men, is this young person a bedroom dweller? So do they live in their bedroom eating junk food, playing games until 3 a.m? And you can see how that young person, it would be a lot more likely to develop things like type 2. So that's probably where that link comes from.
But I think in terms of routine screening, the answer is no.
Yeah. No. Is there any more coming through? No. I think that's it. Anyone else got any questions from the floor? Yeah?
I'll just make a point about what you said about how we see patients, because obviously as diabetes nurses, which we all are, we're sort of very channeled in what we do, and we haven't got experience in dealing with autism a lot. So some of the things you're saying, I'm thinking, I did that, but I did it out of sort of reading the person. So a person would come in and I'd say, oh, and I could see by their face, and we'd have a chat, and I'd say, oh, and she said, I don't like waiting in the waiting room. So the next time I booked her first on my clinic. So you just sort of do it, but you're not doing it with the full knowledge of why you're doing it sometimes. And I remember seeing a patient who'd got mental disabilities, and I went out to see him because he lived in a sheltered accommodation, and his diabetes improved straight away as soon as I've been out there. So those simple tips, we need those somewhere for us to just be ingrained, really. I think it's amazing. Sorry.
So, I mean, I think the point you're making is that we can all learn how to support people with autism better. But if we rely on our experience in order to change our behaviour, potentially that could be too late, because we could have lost the engagement of that person before the penny drops about what the right thing to do is. So I think that's where some of the training comes in before, so we can actually start to preempt some of the things that you describe. You know, so learning about not having somebody in the waiting room for ages. You know, think about booking people first appointments in the day, and on the other things that you described. So I think with a little bit of forethought, we might actually be able to get a lot more out of those consultations.
Yeah, that's amazing. Thank you so much, Richard. That was really good.
Thank you very much.